Very warm welcome to this morning CME. Today, my topic is pain management in minimally invasive cardiac surgery. I am Dr. Mohammad Sharif Hasan, specialist cardiac anesthesia in Square Hospital. Thank you for joining us today. Before pain management, I would like to share one thing. What is pain? What about pain for this man? Is he feeling any pain or not? Then what about this man? Simple syringe can exaggerate excess pain for this man. So actually the definition of pain is variable, but there is a definition given by the ISPM. I'm not going that today. Before management, I would like to share the incision given in minimally invasive cardiac surgery. There are lots of approaches that surgeons perform incision. I would like to share for my anesthesiologist, that is in aortic valve approach. In aortic valve approach, minimally invasive approach to the aortic valve can be accomplished with a wide range of incision. The most commonly used approach is hemisternotomy, usually extended in J shape into the right fourth intercostal space. Here you will, pointer is, this is a pointer. This is the J shape incision that goes to the fourth intercostal space. Then another aortic valve approach is right anterior thoracotomy, that is RAT, with a 4 to 6 centimeter incision is made over the medial aspect of right third intercostal space, is the incision site. Another approach of mitral valve is right mini thoracotomy. To approach the mitral valve via right mini thoracotomy, a 4 to 6 centimeter inframammary incision is made in the mid-axillary line for primary access and augmented as needed with stab incision. This primary incision is made 1 to 2 centimeter inferior to the nipple in the men and about 1 centimeter above the breast crease in women. Next is very much common in our hospital is coronary artery bypass grafting, which is called mid-cab, minimally invasive direct coronary artery bypass. It is a broad term for CABG performed without median sternotomy. Mid-cab most often entails either single or multivessel CABG through a small thoracotomy. One approach, as described by McGinn and colleagues, uses a 4 to 7 centimeter anterolateral thoracotomy in the left fifth intercostal space. This is the left fifth intercostal space we use in mid-cap. All these incision marks, we need to know the nerve supply of these spaces in the third intercostal space, the aortic approach. Also in the fourth intercostal space is also aortic approach, and the fifth intercostal space both in right and left side due to mitral valve and CABG case. Next is the spaces are innervated mostly by the thoracic intercostal nerves and their branches from T2 to T6. The most contribution of our chest wall. These are the branches, and another nerve is the lateral pectoral nerve. This is the lateral pectoral nerve. Sorry, sorry. This is the lateral pectoral nerve. Another is medial pectoral nerve. This is the medial pectoral nerve, and this is the latissimus dorsi or the serratus anterior nerve. These three nerves come from the brachial plexus, and another the most important branches of thoracic intercostal nerve is anterior cutaneous and the lateral cutaneous. We need to know this nerve supply and the nerve division, nerve area, because we have to block these nerves. Then what can we do? There are a lot of nerves here. We can see there are a lot of nerves here. So what can we do? We can do is the multimodal approach. I have already mentioned in my previous lecture in pain management in cardiac surgery that I have discussed broadly there in multimodal approach, but now I am not going to in this multimodal approach. I will discuss about the regional analgesia for MICS case. There are a lot of regional anesthesia like intrathecal, epidural, high thoracic epidural analgesia, nerve block, intercostal nerve block, paravertebral nerve block, interpleural block. In case of MICS, we need to know the intercostal nerve block. This is the intercostal nerve block. Another is paravertebral block, and the serratus anterior block and interpleural block. Here I will discuss the intercostal nerve block details and the serratus anterior block details, but not the thoracic epidural or paravertebral block due to the in cardiac surgery we use heparin. Due to heparinization, there are chance of large hematoma or bleeding in the thoracic epidural and paravertebral block. So now I will discuss about the intercostal block technique. This is a blind technique. Then I will go for the ultrasono technique. In case of here I will discuss about the intercostal block in sedated patient, because we like to if we give this block before induction, the position of the patient will be variable, because in before induction the patient can be positioned in sitting or in prone position, but we can do after induction we can position patient in lateral position with the side to be blocked uppermost. The arm should be abducted and flexed to retract the scapula. Palpate the appropriate vertebral level. Mark an insertion point 4 to 8 centimeter lateral to the midline. Here I have shown it. Here is the point. It should be marked before injecting the needle. Just lateral to the paraspinous muscle. Just lateral to the paraspinous muscle. This is the paraspinous muscle over the caudal end of the corresponding rib angle. Then we should prepare the skin. I'm not going details in prepare the skin. Then a 50 millimeter needle attached to a syringe containing the chosen local anesthetic is introduced to contact the bone. Here you will show the picture. First you have to contact the bone. Then the skin pressure is relaxed and allowing caudal direction. This is the caudal direction to reach the space, which is then advanced 3 millimeter below the rib contact point with 20-degree cranial angulation. This is the technique, 20-degree cranial angulation, sorry. Then the needle should not be advanced greater than 8 millimeter deep to bone contact, as the intercostal vessels are in close proximity. Careful aspiration should be performed to avoid intravascular injection. After aspiration, 3 to 5 ml of local anesthetic plus epinephrine plus, this is plus minus epinephrine is injected. 4 to 8 hours of analgesia can be expected with 0.5% levobupivacaine or ropivacaine. So this is the dose of, if we perform single shot or 1 or 2 space, we can adjust the dose, we can give higher dose. Dose means this is high, we can use high volume, like 10 ml of local anesthetics. In case of continuous nerve block using, we have to use the nerve block catheter. This is the picture of nerve block catheter. we should use in case of if we want to provide analgesia for long time, like zero POD, first POD, or even second POD, we can use this catheter. To insert a catheter, select an injection site as medial as possible. Using an 8G2 needle, direct this medially and insert the catheter 5 centimeter, as like I have mentioned all previously. In case of continuous infusion, we have to give 0.1 ml per kg per hour of 0.1 to 0.2% levobupivacaine or ropivacaine. That will prolong the analgesia. We can use it in our CTICU. Now, the ultrasono-guided intercostal block technique. This is very simple and very much easier technique in ultrasonoguide. Here you can see the probe, that is the in-plane probe. We can see these structures. There is skin, subcutaneous tissue, then the external intercostal muscle, then the internal intercostal muscle, and lastly innermost intercostal muscle. Between the internal intercostal and the innermost intercostal, the nerve lies in the groove of rib. This is the neurovascular bundle. Here we should inject the local anesthetic. You can see in ultrasonoguide, this is the picture. This is the external intercostal muscle. This is the internal intercostal and innermost. Between the innermost and internal intercostal muscle, there is the nerve lies here, but we should give it very cautiously as the artery runs just medial upper to the nerve. Now I will show a short video of intercostal nerve block.
Here a demonstration intercostal nerve block pain.
Here you see that the rib, here is the rib, this is the another rib, and this is the pleura. And the needle is now the serratus anterior plane block. This is a very simple method, but this is the expert hand need due to it will provide a large area to cover the analgesia, because it will block various nerves like anterior intercostal, anterior cutaneous division of intercostal nerve, and the lateral cutaneous, the pectoral nerve, and the long thoracic nerve. This is very easy, but it will be given by the expert hand. Because there is no blind technique for this serratus plane block, we should give it should be given by the ultrasono block. This block is provide comprehensive analgesia to the entire chest wall, depends on volume. And this is very important, that it depends on the volume of local anesthetic. This is quite an easy block with great success rate and excellent analgesia in postoperative case. Here you can show, I am showing the anatomy of ultrasonoguided. This is the latissimus dorsi muscle in ultrasonoguide. This is the serratus anterior muscle. Between these two muscles, there is a fascial sheath. Between the latissimus dorsi and serratus anterior, there is a fascial sheath and the artery. Here we will block the nerve. Here it will block this serratus anterior nerve or long thoracic nerve, and the volume can make this block longer. This is the another view of ultrasonoguided technique of giving serratus anterior block. Here you can see the 5th rib, 6th rib, latissimus dorsi muscle, serratus anterior muscle. Between these two muscles, there is a fascia, and we will give, we have to give the local anesthetic here. and this is the pleura. There is another video. I'm sorry for the video is very slow here.
Here we see the fifth rib.
Here you will see the muscles that are present. Perhaps slow.
First rib with the pleura on the side. And you can
See the video. The needle is going through the upper. You can see the needle. They will give the local aspirations. There is the artery. You could see the arterial pulsation by the ultrasound. And they will give
It's usually achievable first attempt on that other techniques with the needle is not learning. You might have several.
there you see the unzipping of the vasculature. Yes, it is the local anesthetics. And this is the all of the block of intercostal and serratus anterior plane block. And lastly, I would like to thanks. Thank you very much for listening. Any question?